We're going to get into our last few sessions, including the awards. The awards to the Best Startup, which is a award that's new for this year, thanks to the generosity of Zimmer Biomet. They gave us a grant to provide a prize for the best startup, the best presentation of the best startups that we had. But before then, I'm going to invite Dr. Tom Barber to run our politics desk, the policy session that's going to wind up the afternoon. He's an orthopedic surgeon specializing in total joint replacement. He and I go way, way back. He's going to join us at UCSF and running the PeriOperative services, Vice President of PeriOperative Services for UCSF. So thank you, Tom, and tell us a little bit about your political stuff. And
great. Let me grab a mic. Okay, can you hear me here? Yeah, first thing I'll just tell you a little bit about how I got involved in politics. I am an orthopedic surgeon, and so it's a little unusual that I get involved in the politics, but as the chair of the Board of Counselors, thank you, Stefano, chair of the Board of Counselors for the Academy of Orthopedic Surgery, I was the chair just when Obamacare was being considered, and so it became quite interesting to keep track of what was happening in Washington at that time. And following that, I became the chair of the advocacy committee for the Academy of Orthopedic Surgery, which I was on for 4 years, spending a fair bit of time in Washington lobbying for various causes for the Academy of Orthopedic Surgery, and obviously concerning myself with everything related to Medicare policy, to FDA policy, and to legislative things such as MIPS and MACRA that passed during my tenure. So got some experience there. I've got two great folks to lead with me up here. Chick Yates is here as an orthopedic surgeon from the University of Pittsburgh and vice chair there, and he has tremendous experience in a couple realms. He's on a committee with the National Quality Foundation, as well as done multiple panels for Medicare and CMS around value-based payments and value care, and so he has a lot of experience in that sort of regulatory environment, if you will, that he's bringing to the table. And so very happy to have you here, Chick, so thank you. And John Drouin is here. John is an entrepreneur and CEO and also a physician and an MBA from Stanford. So he's got a lot of experience as an entrepreneur in Clarify, and he's going to provide sort of the perspective of the entrepreneur and what's happening from the political spectrum in that way. So I'll cover some of the legislative things. Chick's going to cover a lot of the regulatory things. We're going to talk about a bunch of trends and how they may affect the tech world, particularly in healthcare. And so with that, let me go ahead and get the presentation going. So the first thing I'm going to talk about a little bit is the legislative environment, what's happening on the Hill. I'm glad this table is a little bit empty here, and there's no defibrillator that I see, because I'm afraid that I might get shocked saying that there's not much change happening in Washington right now. There's no legislative issues. In any case, I'm going to talk a little bit about what's happening and where things are going and what we can expect. The first one, these are in no particular order and not in order of importance. This was a brainstorming session we had just to really look at what are the major changes happening legislatively. So the first one was really, will MIPS and MACRA go away? This was passed by a Democratic... MIPS and MACRA are the legislative solutions for payment on physicians. So they're basically payment schemes from CMS using quality-based and cost-based, as well as measures of what we used to call meaningful use, or use of the computer systems to pay physicians. And so they're a big change from previous payment practices, and also include things like bundled payments and APMs, or alternative payment models. So this was a big change that went into place a couple of years back. And it's really being implemented in this year for the first time, and it's gradually being implemented and getting more and more traction. There was a lot of thought when the Republicans pulled off the presidential election that there would be some repeal of MIPS and MACRA. However, I want to reassure you that those were bipartisan reforms that were really brought about by that bipartisan action. So I don't think that these are going to change. And there may be some modifications in the regulatory realm, but they won't go away. And we can talk a little bit more about that. The second one is really a recognition on the legislative side that risk and risk mitigation is important, and basically making sure that we account for risk in any of our models of payment. And this is a recognition on the legislative as well as the regulatory side. We'll talk a little bit more on the regulatory side. The third one that's happened with the new administration is really looking to reduce the regulatory burden, and that's across the board. That's from the FDA to CMS. Part of this plan was to make the CJR program, which was the Joint Replacement Bundled Payment Program introduced by Medicare. They backed off of that a little bit because they've made it not mandatory but optional in many markets, and so they have backed off a lot of the requirements. They've done away with the SHIFT program, which was a program on hip fractures that they were going to do. So they've backed off on a lot of the regulatory aspects of the of these programs. The fourth one was something that was talked a lot about by Trump, and that's to repeal the ACA, or Obamacare as he likes to call it, and replacing it with something else. What's happened is, short of replacing and completely repealing the ACA, the House and Senate were not able to agree on that. What the biggest impact is the reduction or the elimination, essentially, of the requirement to have health insurance, and the penalty piece of that, the $300 that you were fined if you did not sign up for health insurance on the federal side. And so that's been a big change. It is predicted to reduce the amount of health insurance purchased through the exchanges. The amount of that is not 100% clear, although it's been estimated to be in the millions, obviously, by CBO, by the Congressional Budget Office. And the reason I say it's not clear is, like in California, the state legislature is considering a penalty if you do not have health insurance. So if that passes, that would have the same effect that Obamacare penalties would have had. So there may be some state solutions that may reduce the reduction in health insured lives, if you will. And so it's not certain exactly what that impact is going to be. But we don't see that there's any likelihood right now of complete repeal. There has been legislation to incentivize registry development, and there's a lot of interest in that on Capitol Hill and looking at risk-adjusted measures and what that means. And so you will see further legislative action on that, in part to help reduce the HIPAA issues that go along with registry formation, and in part to free up I don't know that there's going to be free up the regulatory environment around registries. There won't be money necessarily available for registries, but there will certainly be a freeing up of that of the regulatory environment. There'll be more and more flexibility regarding alternative payment models and what that means. Primarily, they've been bundled payment models up to now that have been very complex. The CJR program, for instance, was 1,600 pages of regulations. Could have been written in about 200, but it was very significantly made significantly complex by those 1,600 pages. We will probably see a reduction, a relaxation of the rules around physician-owned hospitals, because that was a big issue for the Democrats, not wanting physician-owned hospitals. A lot of the Republicans are supportive in general of physician-owned hospitals, but there's some regulatory things that need to be cleared up in order to allow that. But there will certainly be activity on that. Whether it gets passed or not is another question, and that may help some folks. And the last one is a reduction in funding for medical education. There are significant payments that happen on the federal level for medical education in many, many different forums. One of them was pharmacy payments under the 304B program, where teaching institutions operating in the inner cities or with high Medicaid populations were able to purchase drugs at a lower cost, and therefore be able to provide care more cheaply. That's just one small example that's been taken away recently for funding for medical education. There will be looks that are going to be further at, the IME and GME, which are the direct and indirect medical education expenses, because they're very significant for Medicare, and people see that teaching institutions tend to get a higher payment than others, and I think there's some concern about that in the Republican Congress and Senate. I doubt it will be a lot, but there will be some further scrutiny of that. So those are sort of the legislative trends. I'm going to let Chick talk about the regulatory trends and what's happening in that environment, and we'll put it together. Thanks.
Yeah, and I just wanted to reemphasize that macro was passed by about 90% of the House and 90% of the Senate, so you won't see that going away anytime soon. They were tired of the SGR, which came up every year and bogged them down. The other thing to realize is that both under the Affordable Care Act as well as under the most recent tax bill, Medicare takes a shave. And so you're in a contracted environment in terms of the dollars available from Medicare, and they will be functioning in a cost-saving environment on their own to meet their budget. So that's a smaller pool of dollars going around in that particular payer's environment. In the regulatory environment, as was mentioned, the impact of MIPS and reducing the burdens of MIPS is something that's being negotiated and was very much on Tom Price's menu for the docs. We lost a friend in terms of an orthopedic surgeon being the secretary of HSS, but now he's not there. But the people that are still there are very interested in reducing regulatory burdens, and that waters down some of the impact of MIPS. We have convinced CMS, now I say we, I mean the medical community, specialty societies, in meeting with CMS, that we need better risk adjustment and we need better exclusions in the performance measures that affect the hospitals and affect the surgeons. One of the ways of working this out would be to create cutouts for hospitals that show increases in their medical case complexity or an increase in taking care of those socioeconomic sectors of our society that may be left behind. When you have poor risk reduction, the easiest way to cut your risk is to cut those risky patients, and they become value refugees. It's the unanticipated consequence of value equals quality over cost. The more healthy patients have a better quality outcome and lower costs, and that mathematically gives you a synergistic increase in the value that's given. The more ill patients or riskier patients, conversely, have a much higher risk, and as such they have higher cost and lower quality outcomes, and that Q over C gives you a lower value. And so one of the ways to succeed in what is a competitive environment in value-based purchasing and in macro is to lemon drop and cherry pick. I'm here to tell you that Medicare, I've met the lawyers that Medicare has hired to specifically look at hospitals that have a sudden drop in their case complexity, or they have a sudden drop in terms of certain socio-demographic sectors being cut out. So they're looking for this because they've accepted the fact that there may be some value refugees out there. There, again, overall reduction of reporting burdens. The problem is that if you really cut back on reporting burdens, you're really not talking about registry data, you're talking about data that's from administrative data sets, which are very prone to error and misassignment. There'll be an acceptance of innovations in telemedicine and remote care. This has to happen because it's been dictated and it has to now be somehow funded. There'll be a greater availability of BPCI bundled payment care initiatives, or some version of that as time goes along, and other bundled initiatives for interested systems. And that's an inevitable consequence of the fact that Medicare has less money, because bundled care for Medicare is off the top something that they win at, because they get to set a price lower right off the bat. The value-based purchasing will not be going away either, because value-based purchasing has losers and non-losers, but there's no winners. When you're in a value-based purchasing environment as a hospital, you're trying hard not to be one of the losers that gets penalized, but nobody gets a bonus. So that's money saved by Medicare, so look for that to continue. It's legislated, it's in there, it's going to be part of the picture. There has been active, this is good news for entrepreneurs, there's been active efforts to reduce the regulatory burden from the FDA, and again, more of a continued shift towards care at home, if at all possible, and reducing the utilization of skilled nursing facilities, especially in a post-operative environment, which is where I live. So I'm going to hand it over to Jean for now.
Thank you. Okay, so I'll take just a quick step back in history, maybe look for a tad bit of audience participation here. The most impactful regulatory reform in the last 40 years, not just in the US, but globally, what was it?
Financial markets?
Financial markets in healthcare. Oh. Yes, the DRG. So the DRG is now implemented in over 60 countries. In Germany, it led to the closure of half the hospital capacity inside of 7 years. Okay. Bundled payments and Medicare Advantage, in particular, have the potential to do the very same thing in terms of the scale of the change in the way the actual system is organized. Because the one thing that hasn't changed across all of this turmoil is that in healthcare, if you want to be successful, you'd better follow the incentives and the money. And what's happening now is the thing that's percolating in the background that hasn't changed at all this year is that the reforms that were put in by Patrick Conway, Niall Brennan, Andy Slavitt around new payment models, they're sticking. More states are going on to the Medicaid bundles. Yes, CJR got hacked in half, but BPCI is coming back. And really, the name of the game isn't going to be in BPCI, it's going to be in commercial bundles. If you actually go out there in the field today and talk in particular to orthopedic surgeons in local markets, the leading ones are all trying to figure out how to get into United, Optum, Anthem, Humana, Cigna, etc., and be the first ones to grab the bundle volume. That land grab is going to happen in the next 24 months. And it's on now. That's the big shift I saw between the first 6 months of 2017 and the second 6 months of 2017, and it was palpable at AUKUS. So the pay-for-performance aspect of outcomes tied to valuation of episodes of care, and that moving on to population. So episodes in MA, that absolutely is sticking and moving forward. Now, interestingly, Medicare Advantage is the other program that came through in a big bipartisan way. Efficiency of care being measured and compared, that's now essential for those first two. And this is shifting from just activity-based costing in facilities to care across the entire continuum and beginning to look at what happens before. There's increasing surgeon-directed risk reduction, which follows from that. What's really happening here, though, is there's a unique opportunity for physicians and in particular surgeons to take back control of their destiny, because if you volunteer to take on the risk, it's not just a small impact if you run through the numbers on income. Surgeons can increase their incomes 3 to 5 times or more. So 3 to 5 times if you take on bundles, and if you end up taking on population risk, it's even more substantial. Registry data trumps, this is the key point, static administrative data. Administrative data that is linked to other data sets can be enormously useful. The administrative data we've had to work with so far has been awful. So that's the distinction I'd make. The other thing to remember is administrative data often initially comes from clinical coding. It's just that it's gotten an exceedingly bad rap, and deservedly so, because what's been provided to administrators and clinicians up till now has been stuff that's 6 to 12 months old, and when you actually get what inevitably comes in spreadsheet form, Even though, by the way, in every other industry it's Tableau or better, okay? And you end up saying, okay, but what's the so what here? That's changing. And it's the linkage of all that data that's going to enable the precision of insight to be able to manage that risk. Interestingly, we could have a picture here of the physician's workstation at Zuckerberg General Hospital. So the general here, post having gotten $1 billion from the Chan Zuckerberg Foundation. And if I showed you the picture, it is still a terminal with Windows 95. There's 2 pagers there. There's a phone that's still the one where you dial this way, right? And so the question I'd ask is, in financial services or logistics, would you ever dream of managing risk in that way? Absolutely not. We're bringing in the tools to do that now. It is going to lead to a sea change because the payers are waiting to transfer the risk. It's just that they haven't had the confidence to do it. They themselves don't have the back office, and the providers haven't been ready. But again, we've reached the tipping point. And again, the greater availability of data sets just facilitates that. And if I had to summarize, I mean, the big 4 trends that are finally coming to bear here are new payment models, the ability to link the data, the ability to engage the patient in ways we haven't been able to before, and interestingly, the willingness of the most entrepreneurial clinicians to be the bearers of the change. Now that's something that's highly different from the last 40 years. Because really with the advent of the DRG was the beginning of clinicians basically becoming a bit passive to what was coming along. And I think what you're going to find is a very different thing in the next 10 years. So I'm very bullish on innovation, and I'm very bullish about the role that physicians can take in driving it.
Next slide. Yeah, I'll run it through. So what are the opportunities and risks in this particular audience? I think improved risk modeling, especially from the commercial sector where there's an opportunity for better data. Telemedicine, apps, patient monitoring, think small, think big. We need linkage of large enriched patient level data sets, and we need linkage that makes the electronic medical records talk to each other. There's a huge opportunity here because there's so much information still being dropped, lost, and never found when patients change from one hospital or one doctor to another. And it's a back-breaking process trying to get that information from one place to another. That shouldn't be happening in 2017 or 18. I think that we're going to be, there's a trend towards clinical practice guidelines being used by the government, and at some point they're going to be supplemented with AI. I think that's great, but if you don't like the making of, if you really like sausage, don't watch sausage being made. Let me tell you, clinical practice guidelines are not a clean process, and then applying them or teaching the computer what we don't really know isn't necessarily the best thing. So watch out for some resistance in that regard. We need to have better registries. I speak about the American Joint Replacement Registry and always say that when it grows up, I want it to be like the Society for Thoracic Surgeons Registry, which has been around for 30 years and does a beautiful job of risk adjustment and has buy-in from all the surgeons, and now is required at every center for cardiac care. I think there's opportunity for digital workflow and management tools for bundled payments and population risk that again, I think it's, as Jean said, it's going to be in the commercial sector where it's going to be most robust because the CJR and the current Medicare requirements are less flexible. And without a doubt, there's going to be further vertical integration in healthcare. I work for a very large vertically integrated healthcare system with its own insurance, and the insurance brought in more money than the clinical work. Now that's something to think about. Likewise, we compete against a large insurance company that decided to buy a hospital system. We're not just talking hospitals merging, we're talking about the vertical integration of the entire complexity of delivery of care, from the dollars from the patient going into their premiums to the actual provision of care at the bedside. So back to Tom.
Hello? Yeah, there it is. Thanks, Chick. Well, we have a bunch of questions that we can ask, but more importantly, I'd like to open it up to you guys and say, who would like to ask a question from this? Yeah, Steph.
Sorry, I don't think moderator, but I want to know a question for Gene. So, when you talk about assuming risk, it's easy to do until something bad goes wrong. You have a $2 million patient. Is there a number at which the case volume seems to balance out the risk? How big do you have to be before you can assume risk and actually come out actuarially whole?
Yeah, that's a question that has to be worked out at negotiation level. The key thing there is whether or not you have stop loss. And you can put into any kind of contract for shared risk or for bundled care some sort of stop loss. There's actuarial risk that somebody might develop gangrenous cholecystitis after a total knee replacement, but it's not necessarily on you that happened and they're in the ICU for 3 weeks. So if you can negotiate stop loss, you're protected, then it's not a volume-related incident. I think that the issue of taking on risk and volume comes down to, do you have the capacity, do you have the economy of scale to be able to manage your information and smooth out variability? Even in the small, less expensive cases, you want to make sure that you can smooth out your variability over volume, and you have the volume of scale to be able to provide all the information you need.
Yeah, the other thing I'd point out is that if you look at the systems that a bank or a FedEx or an Amazon use to manage risk, not just historically but predictively, I would argue you need to be at least the size of UPMC to be able to afford that in the long run. So what's going to happen for physicians is there will be organizations with the balance sheet. Could be a Stryker, could be an Amgen, could be a private equity funded company with $300 million in the background put in by Temasek or something like that. And I think you might see the rise of all three of those models in addition to the... so part of the vertical integration is going to be driven by the fact that, I hate to say it, but the investments that were made in the EMR over the next 10 years are going to pale in comparison to the investments that need to be made in order to truly compete and manage the risk.
Let me add to that. And in addition to that, there are huge advantages for the provider to become within the macro system and a qualified provider on what's known as advanced alternative payment models. It's a better deal than being part of the MIPS process. If you guys don't understand, just believe me. And so being part of the AAPM is a good deal. To help surgeons get that, AUKUS is the American Association of Hip and Knee Surgeons. I'm working with Bill Drouin and some other people, and we're trying to develop virtual risk models or virtual hospitals where you could take maybe 15 hospitals in Appalachia and link them together through somebody like Stryker or some outside vendor that has skin in the game for that we could then help those surgeons participate in that and have that volume of scale that they need.
Yeah, let's go on to another question. Other questions? Yeah.
We've collected data for the past 50 years plus. We have our outcome measures that we believe in. We're talking about the new era of the digital era and how we collect data that we don't know what it means. Where's the role of the societies today in creating new outcome measures that they are digital outcome measures that measure maybe kinetics rather than kinematics or rather than a range of motion, and trying to just get us something that is more precise than what, don't confuse me with the facts I've made in my mind.
I got it. I was very involved with that at the Academy of Orthopedic Surgery, starting helping to think about the measures and what they mean. And the research arm of the Academy of Orthopedic Surgery was involved, but to get a measure approved, even if it's clinically reasonable, on a society basis is at least $100,000. Okay, because you've got to validate it, you've got to prove it, you've got to move it forward, and you've got to have a lot of consensus. So it's $100,000 spent just to do it, but you also have to have the collaboration of all of the members of that society to make it work. So, yeah.
That model is true if you're going to go through the National Quality Forum endorsement process, which historically has been the ticket for CMS to then use the measure. Now, most of those measures have been for hospitals, especially in joint replacement. Built into MACRA, and I met the staffers that actually inserted this. They inserted another way for a performance measure to become endorsed, if you will, by CMS, and it can be endorsed by the specialty society through one of its journals, by its board of editors. So if it goes through peer review by a set of editors, it can become an actual measure, and that's not going to necessarily affect the hospital valuations and their metrics, but it certainly is going to help in terms of getting some of the performance metrics into place for MIPS. And I would think in terms of outcomes, the problem is that when you start talking about kinetics or range of motion or this or that, you're talking about a lot of burden. How about a simple, I'm the chairman of the committee for the Academy looking at performance measures for total knee. How about a simple measure between 9 and 12 months that's a pass measure? Patient acceptable symptom state. And all you do is, I'm not going to paraphrase, but given what your life is like and what you do, are you happy with your knee replacement? Now that's a very simple thing to ask, and what's beautiful about it is that you as the surgeon have some control over that risk adjustment. Because going back to when you first asked that patient or you first offered the surgery, if you've gone through careful shared decision making, and if you have actually done proper patient selection and you have managed patient expectations, you're going to have a happy patient at that point 90+% of the time. The person, let me put it to you this way, the person I don't want to operate on, and I tell patients this, is the guy that's pissed off that he has to borrow a golf cart for the last hole of 18 holes. After his knee replacement, he's going to be upset that he has to use the golf cart for the back 9. Now, the guy that can't get from his car to the putting green is going to love his knee replacement. So it means, in that sense, that then it hits about 4 different domains that CMS once hit, including shared decision making and expectations.
Right. We're going to have to,
just only a small comment. It depends on who's asking the question. Yes. If you ask the question versus your nurse. The idea of having a quantifiable measure versus a subjective measure, it's big. And we all know it. That's where the digital world is. And
that's getting into the mechanics of performance and outcomes measures, and I understand that.
But the bottom line is, in answer to your question,
psychometric
societies
testing
have to be engaged, and we have to get through this. We have to be. So anyway, I think we're running out of time. We could go on for days about politics and regulatory aspects. We'd be happy to take questions afterwards, but I know Stefano needs to get moving, and we have some tasting to do, I think.
Stefano wants to give awards.
Thank you. Thank you very much. Thank you, Chip. Colin, great job. Thank you.